She oversees transfusion medicine training and education of healthcare professionals in public and private hospitals and tertiary institutions. She recently co-developed SANBS's first digital learning experience portal for internal and external healthcare professionals to expand access and on-demand training. She currently chairs the SANBS Broad-Based Black Economic Empowerment Strategic Initiative. She is passionate about developing capacity-building relationships within Africa through digital and advisory services. She is an ISBT Working Party member and is one of the co-authors and developers of the University of Free State PBM Short Learning Program for Nurses. She's going to be talking to us about the overview of alternatives to blood, a literature review. Thank you so much and welcome her onto the stage.
Thank you. Good afternoon, ladies and gentlemen. Thank you very much for that wonderful introduction, Tasneem. Won't be long. I promise that I'm standing between you, my colleague, and going home. So it's an honor and a privilege. I'll just take you through a journey, just an overview of the review of blood and blood products and alternatives thereof. So the journey is quite simple. It's the history of blood, where we come from. I'll describe the review that we've done, the literature review, and then the future outlook. Where do we see ourselves going in future? So the history of blood, most people know the blood groups A, B, and O, but they don't know that it comes as far back as 1492, where the Pope thought, maybe if I can drink blood from these 3 Jewish boys, maybe it could help my health. And only later on, over about the next 100 years, Dr. William Harvey then only correctly described the actual blood circulation, that you don't drink it, it's different systems, okay? There was then Dr. John Baptiste, who then showed that actually he did his first xenotransfusion, where he took blood from a sheep and transfused successfully a sick child, a 15-year-old, as well as a butcher, and they both survived. But unfortunately for him, it was Mr. Moroi who had a mentally ill patient, was transfused and died, and he was found guilty of murder, and transfusion was then banned. Only in the 1900s, we found that Dr. Karl Leinsteiner then discovered the ABC groups, now that we know as AB, and O. And of course, other timely discoveries happened where we got sodium citrate that can stop clotting. Now we were able to store the blood, and that's where we came up with the first blood depot. Now we've got blood banks all over, right? Because we can then store these. Just a bit of history. On the alternatives, we did a quick literature review to see what has happened over the years, because we've always been talking about these alternatives or blood substitutes, or alternate artificial blood. So by definition, any product that may be used to stimulate the production, fulfill or mimic the function, or replace the contents of biological blood in part or fully is called an alternative. And of course, I'm just going to touch on these 3 broad topics: alternatives to red cells, alternatives to plasma, and alternatives to platelets. Okay. When it comes to red blood cells, those that can stimulate red blood cell production, erythropoietin or iron replacement, we've got those that can fulfill our hemoglobin-based oxygen carriers, as well as perfluorocarbons, and those that can replace red cells. What else can we do? I'll touch on each one. Those that stimulate is our recombinant human erythropoietin. These are drugs also called ESA. What's important, we've got Aprex and Remocon. They were used for patients with end-stage renal failure. And in FDA or USA, it was only for those that had that black box warning, poor patient outcomes. And in 2018, SAPRA also issued an adverse reaction statement for Aprex that was used here in South Africa, where they showed that there were risks of severe cutaneous adverse events, including Stevens-Johnson syndrome and toxic epidermal necrosis. And of course, some other study done in KZN showed that they also developed antibodies to this ApoBeta. With iron replacement, we know that we've got a global program of anemia, that over 2.3 billion people are living with anemia, of which 1.4 billion are actually iron deficient. So replacing iron is what my colleague is passionate about. She's actually the lead consultant for patient blood management. So she'll be sharing more about patient blood management. It's basically early detection of this anemia and managing it accordingly. She'll go into details with that. And hemoglobin-based oxygen carriers, those that can fulfill or mimic, these were thought to going to replace us blood donators everywhere. But, I mean, it was developed over 4 decades ago, but they're still not yet in the market in South Africa. Why? We've got HemoPure, because the early ones face lots of challenges. They cause vasoconstriction because of that oxidative toxicity. The hemoglobin is no longer in the red cell, and all the other clinical trials were abandoned prematurely. But this HemoPure one, which is bovine one, it was used in Russia and FDA approved. In South Africa, it was used but likely to be also withdrawn because there were 13 meta-analyses that also showed the risk of increasing death and myocardial infarction. With perfluorocarbons, this was also thought to be something that's going to be wonderful. Just look, we would be putting up all these white bags everywhere. Why? Because they thought that this is a high gas carrying capacity. It can have oxygen as an oxygen carrier. We can just use that. But unfortunately, it still could not deliver the same. Only 30% of whole blood, what whole blood normally delivers oxygen. And it also had such a long half-life that it would stay months in your body, weeks to months, and had side effects that were flu-like symptoms as well as thrombocytopenia. Right now it's only used in Russia and Mexico, and of course not in South Africa and USA. Other substitutes, we know the replacement product or technology, autologous, where you donate for yourself for later reuse, or you use intraoperative cell salvaging. I know there are several stands here with people with cell salvaging machines, so I won't go into that one, but just know that it's indicated if your estimated blood loss is more than 500 mils and you're just connected to a machine, you take out the red cells, and then they wash them and return back to you. Okay. The last one is acute normovolumic dilution, where we take out the red cells, but now we give you normal saline and later give you back that volume. The plasma substitutes, we've got coagulation factor concentrates. The donated blood is used. When you donate whole blood, we actually divide it into plasma, platelets, and red cells. That plasma, we then give it to another company called NBI, National Bioinstitute. They then do these plasma human-derived factors or factor concentrates. And that's, I'm sure most of you will know of bioplasma, FDP, fried dried plasma, hemosolvent, and hemosolvex used for hemophilia. Platelet substitutes, we also have thrombopoietin mimetic or thrombopoietin receptor agonists, basically also causing stimulation of platelets in the bone marrow. Those that can fulfill, there are several, those that are optimized platelet adhesion to the endothelium, or where there's increase in von Willebrand factor levels, like for example desmopressin, or where we increase the formation of cross-linked fibrinogen and activated recombinant factor 7. We've got those that decrease fibrinolysis, for example tranexamic acid, and the last one, fibrogen-coated albumin particles, so just making them mimic the platelet action. And the last ones are artificial, that can replace artificial or modified platelets, cryopreserved platelets, or semi-synthetic particles coated with platelet receptors, and engineered nanoparticles. This is now the future, and infusible platelet membranes. Most of those, I think we're only mainly using, in South Africa, we're not even there at the cryopreserved platelets yet. Okay. Now the future. stem cells. I know everybody's been talking about, oh, you're collecting stem cells. What are you doing with it? Right now, what we do is just we can collect the stem cells, store them for you for later infusion for oncology patients. But the history of alternatives, they've come up with techniques where they can reprogram these adult cells, for example, skin cells, into induced pluripotent stem cells, and then you can have nerve cells, blood cells, liver from those. The history of all that, it's taken years. I think since 2006, they thought this is going to be done already, but as early as 2006, they started with mature skin being used back into pluripotent stem cells by Yamanaka, and then red cells were developed. We had this, I think, converted pluripotent stem cells in red cells, and it took about 21 to 31 days that they used in the lab. But they needed so much stem cells just to create small amount of red cells. And the last one was that in 2017, a consortium with different universities, they decided, no, let's do this. And it was an 18-month trial, human trial, where red blood cells that were produced in the lab were actually given to patients, these 10 volunteers, but they first gave them red cells, and then later on, 6 months later, they gave them the manufacture just to see if they had any side effects. They did not, but there were only 10. And in 2022, they also did it with only 2 patients. They also did not have side effects. So clearly there are limitations. Limitations are the higher costs to manufacture all these cells from stem cells. And for England, they said actually it costs over 200 times more than the cost of a standard unit of blood. And you know that that won't work in our setting. He's shaking his head to say already people are saying the blood unit is expensive, but why would we then create something that will be even 200 times more? And more studies obviously need to be done with more number of people. So in conclusion, ladies and gentlemen, I did say I'll be fast so that my colleague can then talk to you. There are no true alternatives to blood. We still need you to come through and donate blood and blood products. But in the near future, more research needs to be done. We've got patient blood management that my colleague is passionate about. She'll tell you more how we can make sure that this scarce resource is not used inappropriately, and the use of other drugs that are out there that could assist. So, having said that, ladies and gentlemen, thank you very much. I'll hand over to my colleague, Petrolis. Thank you. References, and there. Thank you.
Thank you so much. Before you go, are there any questions? No? I think it's
we'll
safe
take
to
them
say that
after.
this is one area that AI cannot replace.
Yes.
If anything is to go by your
We still need
presentation,
you.
we still need the human arm.
Thank you.
Let me just get my...